I would like to welcome everyone this evening to another MDA webinar during the COVID-19 pandemic. Tonight, we're going to be discussing COVID-19 and the dental team. We have three outstanding speakers who are leaders on our MDA task force on reopening dental offices. They'll be speaking on back to work, frequently asked questions in the cloud of COVID. We have Dr. Vince Benevenia, who is a board of trustee member, as well as a practicing oral and maxillofacial surgeon. We have Dr. Marie Fluent, who is a well-recognized infection control expert. And we have Dr. Chris Smiley, who is our MDA journal editor, as well as a practicing general dentist. I would like to thank everyone for attending this webinar this evening. And now I would like to turn things over to Dr. Fluent. Thank you.
Thank you, Dr. Marat. And by the way, we need to extend a warm welcome to you as our new president of the MDA. We look forward to your guidance and leadership in this year ahead. So thank you for the warm introduction. And thank you to our friends at MDA for hosting this and all of the work behind the scenes to make this webinar possible. Before we begin, I'd like to share a few disclosures with you. Dr. Benevenia and Dr. Smiley have no disclosures to report. I, on the other hand, am a key opinion leader for Hugh Freedy, a speaker on behalf of SciCan, and I am an educational consultant for the Organization for Safety, Asepsis, and Prevention. That is OSAP, and that is our one and only infection control organization dedicated exclusively to dentistry. It is a nonprofit organization, so obviously this is just for out of the goodness of my heart, so to speak. A quick disclaimer, the information that we are presenting this evening is not meant to be construed as legal advice or medical advice. It is only intended to mitigate the risk of transmission of the coronavirus in the dental setting. So for more up-to-date information, we urge all of you to look for the CDC website, World Health Organization, state and local health departments, the American Dental Association, and of course the Michigan Dental Association for current guidance and recommendations as we progress through this crisis. Today, we're going to recognize that the first wave of the global pandemic is behind us and that dental practices are now preparing to resume dental care, routine dental care that is. Some practices are already well in action and other practices are still in the preparation mode. So whichever phase you are in, know that this presentation will be beneficial, we hope, for all of you. We know that our policies and procedures as far as infection control have dramatically changed, and we have new guidance for daily practices. So we're hoping to address some frequently asked questions that have been posed to the MDA, and Dr. Chris, Dr. Vince, and myself have divided these up to go through them with you. So we're going to talk about frequently asked questions, discuss the guidance that has been posed to us from CDC, OSHA, MDA, and of course ADA. And we're going to list some resources available to you. And these are most likely on the bottom of each slide, the resources where we obtained the evidence-based information to share with you on each slide. So without further ado, I'm going to pass the microphone over to Dr. Chris Smiley, who will tell us how and why we follow community rates of disease incident. Chris?
Well, thank you, Marie, and welcome everybody. Great to be with you this evening. To start with, we're going to discuss a little bit about why the CDC has asked us to keep track of community rates of disease incidence. And this is a call that's also reflected in the ADA's COVID-19 hazard assessment tool. And in that tool, you will find that there are resources that you can access from community, such as county health departments. Johns Hopkins University has a nice tool that you can access by zip code to take a look at trends. So if we take a look at the next slide, the ADA's COVID hazard assessment tool puts forward a metric that they feel is probably best for you to be following as a practitioner. And that is to take a look at trends, not just a snapshot in time about where things stand in our community at this moment, but more a trend over time, and look at the number of positive test results that are coming forward based over the total number of tests that are being given. So if we take a look at the next slide, we have a very wonderful tool here in Michigan that is unique for our state. And this is something that I would recommend all practitioners bookmark on their laptops or on their office computers and take a look at it on a regular basis. And it's the MySafe Start map at the website listed there. And that shows a map of the state of Michigan, and county by county, we can take a look at by phase where our location of interest is with the prevalence of the virus in the community. So if we take a look at the next slide, I have shown how this was from the other day, showing Grand Rapids, Michigan in Kent County where I live. And we can see that based on the phase, it is in phase 3, based on this tool that the University of Michigan School of Public Health helped to develop. And being in phase 3, that means that things are flattening in Grand Rapids. And we see that the number of positives is 4.8% of the tests that are given. So more importantly, on the right-hand side of the screen, we see that the trends are there over time that show that things are improving in Kent County at this time. So how would you as a practitioner, once you've availed yourself of these trends, use this information? This allows you to apply your best clinical judgment on how you're going to deliver care in your office. So you may decide that based on this tool or the trends that you're seeing, that the presence of virus and community spread is going up in your area. So you may want to reschedule patients who are at high risk and not have them come in during this time. Or you may choose not to provide certain services and look at providing alternative services. Beyond that, you can also take a look at increased mitigation strategies, such as really making sure that for aerosol generating procedures that you're using things like dental dams, four-handed dentistry, high volume suction evacuation, and things like that that you can find in the CDC guidance. So that is why we take a look at community rates of disease, why the CDC recommended it, but more importantly, to help you understand how, once you know this information, you may consider implementing it in practice. So next slide, please.
Before we go on, Chris, I'm going to interrupt a little bit
Sure.
with a housekeeping measure. The three of us are going to present for 50 minutes, and then we hope to address your individual questions. If questions arise during this webinar, I urge you to go to the Q&A section of the Zoom platform and start typing in your questions, and we will address them at the end of the webinar today. So I'm sorry to interrupt, Chris, but would you go ahead and tell us about certain procedures, and are there any that we are not allowed to perform right now?
Sure. So what we just got done showing you is how to assess the presence of the virus in your community. And that, of course, implies that we don't see this going away, and we see that it's going to be in peaks and valleys for some time to come. So although we've returned to work, the COVID virus remains to be a presence in our community. And because of that, the CDC recommends avoiding aerosol generating procedures whenever possible. And avoiding may be a strong word, perhaps limiting whenever possible. But we also recognize that by returning to work, the aerosol generating procedures will be provided. So are there any procedures that are not allowed to be done right now? No, there are not. But we should limit to alternative procedures when appropriate, as I had just discussed, such as doing non-surgical management of decay, perhaps selective polishing, whenever the presence of virus is elevating in our community. You want to take these to consideration even greater. And recognize that to address risk, standard precautions, including appropriate PPE, should be used when delivering any aerosol generating procedure.
Great. The next question I'm going to address myself. Why is there a discrepancy between OSHA and CDC guidance? Well, historically, I need to tell, before I answer that question, I need to share a little bit about each agency and what the purpose of that agency is. CDC is an advisory agency. It is considered our nation's primary public health agency. That is meant to protect us from all type of infections and situations and hazards that may exist in our country and abroad. With regard to dental infection control, the two principal documents that the CDC have published include CDC guidelines for infection control in the dental healthcare settings, and this was published in 2003. And an update and a summary of these guidelines was published in 2016 in a document called the Summary of Infection Prevention Practices in Dental Healthcare Settings, the Basic Expectations for Care. This document is more like, I consider it two Cliff's Notes that you may have used in a literature class in high school. This document is not meant to replace the original body of literature like Cliff's Notes. It's meant to be a learning aid or a supplement to it. So it's recommended that everybody in the dental profession be familiar with both of these documents. CDC has also come out with many guidance documents and web pages regarding guidance for care during COVID-19. And the one web page that we should all be familiar with is guidance for dental settings. Now, OSHA, on the other hand, is a regulatory agency. And by that, I mean they do have the ability to come in and inspect your offices, possibly impose a fine, and in severe cases, close the practice for a period of time. Hopefully, and obviously that is very, very rare, but they do have that authority to do that. OSHA is mostly concerned with providing a safe work environment for employees in your facility, not necessarily with patient safety. And that in of itself, the second bullet point is the key difference, one of the key differences between the two agencies. The documents we need to be familiar with regard to OSHA include OSHA Bloodborne Pathogen Standard and the Hazard Communication Standard. And of course, OSHA does have a COVID-19 page for dentistry workers and employers. Now, I do want to mention that Michigan does have a state-specific OSHA program, and that is called MyOSHA. And MyOSHA and OSHA are pretty much in alignment with regard to COVID-19. So I refer to OSHA on this page, but I'm very well aware, and I want to stress to you that we all need to be abiding by MyOSHA at this time. Now, with regard to these two agencies, there is one key discrepancy that keeps arising over and over, and that is when to use a NIOSH certified disposable N95. So according to CDC, we should be using an N95 respirator for aerosol generating procedures. And note my key at the bottom of the slide, AGP stands for an aerosol generating procedure. According to CDC, we should be using a N95 respirator for all aerosol generating procedures for patients assumed to be non-contagious per our screening. And if the respirator is not available, use our surgical mask, highest level available, and a full face shield. If a surgical mask and a full face shield are not available, do not perform dentistry. Now, OSHA and MyOSHA say to wear a NIOSH certified disposable N95 for well patients for suspected or confirmed well patients or suspected or confirmed COVID-19 patients for all aerosol generating procedures, and for patients with no or with suspected or having COVID for any procedure whatsoever. So that is the key discrepancy between the two, and it is a nuance in language. And at this point, we are supposed to abide by OSHA and MyOSHA standards and guidance at this time, but know that there is a little bit of wiggle room for your professional judgment based on what Chris Smiley presented in the previous slides. So that leads me into my next question. Do you have to use an N95 mask in order to perform an aerosol generating procedure? And I say, before drawing the line in the sand, consider what Chris Smiley suggested or shared on the previous slides, the degree of community transmission of COVID-19 in your region or county. Consider CDC guidelines versus OSHA standards and OSHA guidance at this time. Look at the PPE availability and consider optimization strategies. Look at your team members and discern whether they are at high risk for severe COVID disease. And these include team members who might be older, 60, 65 or older, those with underlying medical conditions, cardiovascular disease, diabetes, kidney disease, etc. Look at the other components of your respiratory protection program. What engineering controls do you have in place? What work practice controls do you have in place? The wearing of an N95 mask is only a small component of your respiratory protection program. And then consider the written policy of your dental practices. As we know with OSHA and MyOSHA, if it's not written, it never happened, and our policy should be written down. So with that, let's take the microphone back to Chris Smiley, who is going to tell us, should we have patients sign consent forms? Chris?
So, we're all very used to consent forms for procedures that we provide, be it oral surgery procedures or other treatments that we do in our office. However, MDA Legal Counsel has recommended against the need for patients to sign a consent form. In part, that's because if you're following the CDC and also ADA toolkit guidance, with the information on pre-appointment screening process, where when the patient calls, you're asking them the questions about their presence of signs or symptoms and discussing with them the procedures that they will encounter when they come to your office, that basically serves as patient notification. Moreover, I think that with so many opportunities for exposure during a pandemic, the likelihood of an affected patient being able to trace their illness back to an experience at the dental office may be unlikely. So I think that the need for doing a consent form prior to delivering care to a patient in your practice during this time is unnecessary. Now, recognize that the risk of COVID-19 transmission during a pandemic may be lowered, but is not eliminated by following all the guidance that we see from the CDC and the ADA. So is it an entirely safe environment, so therefore we don't have to have consent forms? That's not our point. It is as safe as possible, but we're saying that the need for a consent form really is not there.
Thanks, Chris. I appreciate that, and I appreciate knowing that we're not 100% guaranteeing the safety of everybody, but we're minimizing our risk instead. Chris, I'm going to keep you on the microphone as you address how should I explain why I am charging an extra fee for PPE to my patients?
Well, when you're discussing the resumption of practice with your patients, I think they should be told that the PPE and other COVID mitigation strategies that you're implementing are intended to address their health and safety, but also the health and safety of your team and yourself and our entire community from community spread. Now, these measures come at a cost, and patients should realize that. For instance, in our practice, what I have seen is that prior to the pandemic, we were using level 2 surgical masks, and they came at a cost of $15 for a box of 50. That equates to about 30 cents a piece. And currently, the market price that I'm able to find for an N95 is $7 a piece, and sometimes that's even greater. And these are all costs that go into our per patient encounter costs, and patients need to understand that because our masks are only one component of PPE and the mitigation strategy, which includes all these other things, including staffing and supplies and equipment. So next slide, please. So the MDA came up with an addendum to the ADA toolkit, and that can be found on the MDA's webpage. And in it, the MDA recognizes that compliance with CDC, OSHA, and other guidelines and guidances add to the cost of oral health care. Now, one strategy to account for the increased overhead expense is to calculate the cost of the additional equipment, supplies, and time, and the increased that you should then apply to the individual fees that you're charging. So take your overall increase in overhead and figure out from that how much you need to adjust your individual fees. Now, another solution was initially proposed by Delta Dental Plan of New Jersey, and that was to charge a COVID-19 PPE fee that you charge per patient visit. So if I could have the next slide, please. So according to the MDA addendum, and this is something that you can also find through the ADA, they recommend the use of the preventive code D1999. Now, this preventive code is a by-report code. So that means that you have to, in the remarks section of a claim form, place a remark such as COVID-19 PPE. And anytime you do a by-report claim, typically that gets spit out from auto adjudication and may slow down payment. That said, Delta Dental of Massachusetts announced this week that they are covering the PPE encounter fee at $10 per patient visit. And players including United Concordia, Principal, and others in the Delta system also benefit this service, as well as some in public health. Even though CMS says that they don't approve of doing this, state plans such as the Medicaid plan in Washington state are also covering a PPE per encounter fee that they are reimbursing. So the ADA provides a tool that gives a lot of information that you can make yourself aware of, and it's the COVID-19 Coding and Billing Interim Guidance for PPE. And it's found at that very simplistic and non-complex link that's there. But if you get the slides at the end of this presentation, you'll be able to do that, or search COVID-19 Coding and Billing Interim Guidance PPE on the ADA virus website.
Thank you, Chris. But you're not done yet. Can you tell us, are we allowed to have only 10 people in the office at one period of time?
And you should be so lucky. No, truly, yes, you can have more than 10 people in your office at one time if your facility can accommodate it. So some of the confusion that came forward was one of the executive orders that our governor put forward that limited indoor social gatherings, but that did not limit dental offices. Now this Monday, we're going to see the lifting of safe at home or stay at home orders. So patients have always been allowed to go out to seek dental care, but the whole idea of limiting to 10 is not something that we need to consider. However, the CDC does recommend that, especially during times of high risk, that we should look at only seeing one patient per provider at one time. So a hygienist should only be seeing one patient. A dentist should be seeing one patient. I know in the past, before this era, we would have efficiencies where perhaps we would utilize our expanded function assistants and we would stack patients or maybe fit in an emergency in another room while we're caring for a patient and break away. CDC is saying, make all effort to see only one patient at a time and minimize the number of individuals in your waiting rooms. That may include telling patients to come alone or limit their companions if they need to have someone like a mother or father with a child or someone with special needs who has to have a companion along. And perhaps use the car as a place where others can wait. And make sure that your facility allows for social distancing of at least 6 feet in those instances. When patients do come in with a companion, treat them as you would a patient. So if a companion comes in, they also should be wearing a mask. They also should use hand sanitizer. They also should have their temperature taken and screened as you would for COVID, just as you would a patient. And if they insist on being in the operatory during care, that's okay. Although during aerosol generating procedures, we want to limit the number of people in the operatory, and those who are in should be using standard precautions. So a companion may be offered a face shield. They have their own personal mask. They may wish to use a gown. But yes, you can have more than 10 people in your office if your physical plant, if your facility can accommodate that.
Great. The next question I'll take care of. MDA has received a number of questions about how do I handle nitrous tubing in the COVID-19 era. Historically, with nitrous oxide was used with a sterilizable, autoclavable nasal hood and tubing. And now ADA, the interim guidance toolkit, says that the disposable, the nasal hood should be disposable and the tubing should either be disposable or, if you reusable, sterilized according to the manufacturer's recommended instructions. And this comes from the ADA toolkit in your references below. But having said that, I really want to stress to you that if an item has this symbol, the 2 with a slash through it, that is the symbol for a single-use disposable item. These items are not intended to be used on more than one patient. They may not be able to be reprocessed. They may not be heat tolerant, and we do not know if sterilization techniques would be effective on these items. So because of all of these situations, if your item or dental product or device has this symbol, a 2 with a slash through it, you may not use it on subsequent patients. So look at your nasal hood for nitrous oxide, look at the tubing and look for that symbol. And if it has that symbol, you absolutely must throw that away. And more information about single-use disposable items may be found on the CDC webpage that's listed at the bottom of this page. Now, regarding clinic coats, lab coats, gowns, how often do they need to be cleaned? Should lab coats be washed at home or at the office? Now, the CDC and OSHA guidance state that if you wear a disposable gown, it must be discarded after each use, and a cloth gown should be laundered after each use. But CDC goes on to say if there are shortages of gowns, they should be prioritized for aerosol generating procedures and clinical procedures where splashes and sprays are anticipated. To me, that is a little bit clear as mud, because what are we intended to wear for non-aerosol generating procedures if we do have a shortage? It opens up a little bit of a area of a gray area, if you will. Now, with regarding scrubs, scrubs are recommended to be changed and all other office garb between street clothes and scrubs upon entry and exit to the facility. So dental personnel would be wearing their street shoes and their street clothing into the office at the beginning of the day, changing into scrubs, and at the end of the day, reversing the process. Now, laundry, according to OSHA and CDC, laundry services should be provided either in the facility, or you should have a contract with a laundry service and send it out. And for more information about this, I would advise you to look at a webinar that was recently conducted in conjunction between ADA and OSAP. It involved respiratory protection in the era of COVID. And it can be found either on the ADA or OSAP website, and the link is below. And in this webinar, they suggested that if in the event of a shortage of gowns or disposable gowns, that you may consider the wearing of this to be performance-based, and that is you change when soiled or wet. Now, having said all of this, there are gray areas, and so here are my potential solutions: that you develop a written office-specific policy based on CDC guidelines and OSHA guidance as well, and consider job tasks and associated risk levels. You consider your PPE availability. You consider optimization strategies, and that you can find this information on the CDC webpage as well. Look at your laundry considerations and availabilities within your policy, and make sure that you do encourage your dental personnel to change into and out of street clothing and into office garb upon exit and entry into the facility. Once again, there's wiggle room for professional judgment, but if you have a written office-specific policy based on the guidances that I just shared with you, you should be in good shape. So I hope that clarifies that. Now, Chris, we'll go back to you. Let's talk about fit testing of respirators. Are we required to have fit testing done at this time? And if so, where can this be performed?
Okay, so what is interesting is that the CDC, and they said this on a call yesterday, noted that they recognize that, and I want to get this right, they recognize that practices may have difficulty scheduling fit tests or finding fit test facilities prior to when they plan to open. And they recognize that respirators will be worn prior to the individual actually being able to secure a fit test. So they recognize that this will happen. So just because you haven't been able to secure a fit test yet doesn't mean that you can't resume work yet. But the logical thing here is that if you are going to be wearing a respirator, then you should have a fit test, and that comes with training. So OSHA's respiratory protection plan addresses the need for individuals who do wear respirators to complete a medical evaluation, and that's a form that you can find on their website, and fill that out, and then have an appropriate training for use of a respirator and have the initial fit test. Now, that initial fit test need also comes down to part of that paperwork is the airborne pathogen risk assessment. And if you do the airborne pathogen risk assessment, which is the one thing from OSHA that you definitely must do, it's definitely required that you complete this airborne pathogens risk assessment. You're going to determine for your facility if you must be using respirators, and individuals that must be wearing respirators will then need to be having an initial fit test. And so let's take a look at the next slide. There we go. OSHA initial fit test is required for individuals who must wear the respirator N95. OSHA also has required in the past that after you've had that initial fit test, a year later, you should have an annual fit test, but they've waived that in this era of PPE shortages. So the annual fit test is what's been waived, if you've heard about that. Now, where would you go to have this fit testing done? Contact local hospitals and their occupational health departments to see who they would recommend in your community, or if they would do it for you for outside groups. There are also vendors that you can find through a simple search. But also what we're seeing, and it's a great member service, is many local dental society components are having fit testing services for their members. We've seen this in Washtenaw District. Detroit District Dental Society is now doing this in partnership with Oakland District, and I believe also Macomb, and others around the state are doing that as well. So check with your local dental society, either officer or executives, and see what they are planning for fit testing in your community. But if your airborne pathogens risk assessment says that individuals must be wearing a respirator rather than they should consider using a respirator, then definitely a fit test is required. And if anybody's going to be wearing one even occasionally, it certainly would be wise to have a fit test done.
Thank you, Chris. Now let's switch gears a little bit and talk about wait times between use in our operatory. How long do we need to wait to use an operatory between patients?
Now, don't shoot the messenger on this one. Okay, this is guidance that the CDC has put forward about how practitioners, after providing dental treatment, the operatory after the patient is discharged should allow to stand for at least 15 minutes prior to the room being cleaned and disinfected. Now, that's the CDC guidance. And I want you to recognize that CDC guidance blended with ADA guidance that's profession specific is the best guidance that we have. It's the best evidence out there that we should be following. But that needs to be blended with our own professional judgment and discretion. So this is one that I want you to keep a close eye on, because this is something that is being challenged by the ADA. Their Division of Science is not sure where this came from or why. And if we break down the citation that is there from CDC, you could really argue that the amount of time that one needs to wait may be much longer. It could be hours afterwards if you're waiting for all the aerosol to precipitate out before you clean. I also know, that there are other people who are taking a look at other strategies to make sure that their offices are safe, and that they're perhaps adopting other strategies that aren't recommended through CDC. I recommend that everybody kind of tune out everything that you hear on Facebook, or that you hear what your Aunt Sally's doing at an office that she works at. Really focus on the ADA guidance and the CDC and OSHA guidance, because there are some strategies out there that, although they may be effective, simply are beyond what is recommended and may require unnecessary or unproven mitigation that has even longer wait times.
Got it. Now we're going to get into a series of questions regarding COVID testing, and we're going to invite Vince to the microphone. So Vince, can you tell us, may a dentist prescribe COVID-19 testing?
Hey, thanks for inviting me to the party. I would love to answer that question. Testing, can a dentist prescribe COVID-19 testing? Short answer, yes. Long answer, although you can prescribe testing, the ADA, MDA have not endorsed testing because of problems with reliability, logistics, and costs. The CDC specifically has indicated that you can do it if you want, with some caveats. And I'm just going to read you what the CDC says. Depending on testing availability and how rapidly results are available, facilities can also consider implementing pre-admission or pre-procedure testing for COVID-19, which might inform implementation of PPE use as described above, especially in a situation of PPE shortages. However, limitations of this approach should be considered, including negative results from patients during their incubation period who could become infectious later, and false negative tests depending on the test method used. So there are some big limitations to that, but in a nutshell, if you want to do it, you can do it. Also, one other interesting thing that we found out is that the Hygiene Association has recommended testing of all dental health care providers prior to resuming work. I'm not sure where this came from, but again, as I said earlier, the CDC, ADA, and MDA do not recommend it in their guidance. So that's the answer to question number 12.
Thanks. Now we're going to go on to some specifics about testing. If we have a household member, somebody who we're living with, of a dental team member or a patient tests positive for COVID-19, what do we do then?
So the short answer is that you can have that person work for you if they wear a face mask for source control for 14 days. The long answer is that you have to log their temperature and absence of symptoms daily for 14 days. And they have to not work if they develop even the mildest of symptoms, and they have to get tested. If they're confirmed to be infected by a COVID-19 test, they must meet the CDC return to work criteria, prioritizing healthcare professionals with suspected COVID-19 for testing. So that's the long answer for that.
Gotcha. Thanks, Vince.
Yeah.
Let's go on. We've got two categories of symptomatic versus asymptomatic team members who test positive for COVID-19. So let's start off with what do we do if we have a symptomatic team member who tests positive for COVID-19?
So the short answer of what to do with a symptomatic dental team member, or I'm sorry, asymptomatic team member is
are you on asymptomatic or symptomatic, Vince?
Oh, symptomatic. I'm sorry. Symptomatic. Let's do symptomatic first. The short answer to that question is that with a positive test, they do not work until they meet the requirements for symptom-based or test-based strategy. So the long answer is that the symptom-based strategy involves at least 3 days have passed since the recovery, defined as resolution of fever, and that 10 days have passed since symptoms first appeared. The test-based strategy is that there's a resolution of their fever and there's improvement in respiratory symptoms. They've had a negative test result for COVID-19 and at least 2 consecutive test results greater than 24 hours apart. So that they not only have to have 1 test, but 2 tests to come back to work that are negative, and they have to be greater than 24 hours apart. So that's how to handle a symptomatic dental team member who tests positive.
I like how you give us the nutshell version and the long answer version.
Well, that just allows people to, maybe take a break and go get a cocktail while I'm going through the long answer.
I like it. I like it. So now asymptomatic.
All right, asymptomatic. So if you have an asymptomatic dental team member who tested positive for COVID-19, what do? The short answer is that they do not work until they meet the criteria from the time-based and test-based strategy. The long answer is that using the time-based strategy, 10 days have had to pass since the date of their first positive COVID-19 diagnostic test. Using the test-based strategy, they have to have negative test results from at least 2 consecutive respiratory specimens collected greater than 24 hours apart. That's it.
Got it. So let's move on. We're still in the category of testing, but who needs to be notified if a dental team member tests positive for COVID-19?
So the short answer to that question of who needs to be notified is that you must contact everybody that was in contact with the COVID-19 positive team member. The long answer is that the way you handle this is that you have to conduct a risk assessment, which you have to use your clinical judgment to see if the exposure rises to the level of implementing further steps. So you have to look at things like, when was the date of contact? How long was the contact? How close were the people that were in contact? And are they experiencing any symptoms? The CDC says that you should use interim US guidance for risk assessment and public health management of health personnel with potential exposure in a healthcare setting to patients with coronavirus disease to determine if self-quarantine restrictions are in order.
Great, thank you. And
Also, we're continuing on the next slide, right?
Yep.
Yep. So you have to ask the unaffected staff to seek testing. So in other words, if you have a COVID-19 team member, right, and they are in contact with another team member, you have to ask the unaffected staff to seek testing. You have to the most important thing probably is that you have to contact all the patients who may have had contact with COVID-19 positive individual to determine whether they're symptomatic. And you should recommend that they self-quarantine for 14 days and notify their primary care physician if symptoms develop.
got it. Now, what if a patient is COVID-19 positive?
That's a great question, Marie. And that's my last question, I think. So what do you do if a patient is COVID-19 positive? So can you treat this patient? Well, the recommendation is to defer treatment. That's the short answer. The long answer is that, well, you can actually treat the patient. But if the patient arrives to your facility and they're known to be COVID positive, you should give them a mask and have them wear it if they're not already wearing it. And if the patient is not acutely sick, you should send the patient home and tell them to contact their primary care provider. If they are acutely sick, you should send them to the emergency department. Next slide, please. If emergency dental care is necessary, you follow the CDC's interim infection prevention and control recommendations for patients with suspected or confirmed coronavirus disease 2019, COVID-19 in healthcare settings, including the use of PPE. So provided that an individual patient, you should provide them with an individual patient room with a closed door. So basically cordon them off. You should avoid aerosol generating procedures. And if an aerosol generating procedure must be performed, take appropriate precautions, right? So wear the appropriate PPE, protect you and your staff. Preferably schedule the patient at the end of the day and don't schedule any other patients at that time. And I believe I'm finished with my questions.
That's great. And that's a great morsel of advice to schedule patients who you are suspecting of being COVID positive at the end of the day to allow more opportunity for those aerosols to be settling throughout the day. So good point, Vince. Thank you.
Thanks,
So,
Marie.
on that happy note, Chris and Vince and I did not rehearse ahead of time our individual questions, but one thread that was common in each of our responses was the term professional judgment or clinical judgment. And I really want to point that out, that in a lot of these guidelines, there is wiggle room for you to use your clinical judgment, your best judgment, based on the guidelines that have been posed to us. So I'm glad that Chris mentioned that, and I'm glad that Vince did as well. So at this time, what I would like to do is hand the microphone over to Shauna Owens from the MDA, who will start fielding some questions that have been put into the Q&A box, and keep those questions coming, and hopefully we'll have time to get them all. Shauna?
Thank you, Dr. Fluent. That leaves about 10 minutes for questions and answers, and we do have quite a few, so we'll just go ahead and start. First one, I am concerned about the disinfection of lead aprons. I have not heard anything address this yet.
Chris, do you want to take it over, or do you want me to?
Well, I think that, I mean, Marie, you're the expert, so correct me on anything that I say here. But the asepsis management really has not changed dramatically from what we saw pre-COVID. So the way that you would handle the treatment of your lead apron is no different in my mind than what it was before COVID. Recognize that anything that you have in your operatory that can't be disinfected, think of it like a box of Kleenex tissues or family pictures or anything like that, should be removed from the countertops, because you really can't spray those down or wipe those down with disinfectant and get them good and wet as you should, and then allow them to dry, because then you're really not going to want to be using a Kleenex after it's been loaded up with the disinfectant. So with your lead apron, perhaps not storing it in the operatory where it's going to be bathed during aerosol generating procedures may be considered, but truly you're just going to also wipe it down and handle it as you have in the past. Marie?
Beautiful response. Lead aprons are considered a non-critical item, meaning they do not touch oral mucosa or penetrate oral mucosa at all, and these simply need to be wiped down in between patients. So beautiful response, Chris.
Do you recommend use of aerosol vacuum stations for added suction and HEPA filtration to minimize aerosol in the op room, or is it just the high volume suction?
Well, I'll start off, and I'll have either Vince or Chris chime in, and please do chime in. Given our respiratory protection program, we're coming at this from various angles. And all of the engineering devices and work practice controls and PPE controls are part of our respiratory protection program. So HVE by itself is not the one and only engineering control to be implemented. We also need to consider the HVAC system of our entire office, and particularly our operatories. And if that includes extraoral suction units, that's great, or any other type of mitigation devices such as air scrubbers, air purifiers, devices to redirect airflow and increase circulation so contaminated airs are being blown away from the patient and away from dental health care personnel. All of those are components. So I can't sit here and draw a line in the sand and recommend one or the other, or only exclusively one type of product, but a multitude of products and a multitude of approaches to mitigate transmission. So Vince and Chris, do either of you wish to chime in on that?
I would love to chime in on that. So basically, the idea is to not create a lot of aerosol, but when you do, get rid of it. So anything you can do to get rid of it is great. Like some people are putting fans in their windows to exhaust exhaust the operatory air out the window. You know, a simple thing. It's very inexpensive to do. Some people are having HVAC people come into their offices and put in MERV 13, which is HEPA filters in their HVAC system, and running their HVAC fan all day continuously in their office. So all these things can mitigate and reduce the aerosol viral load that's occurring. And in Wuhan, I mean, the dentists there, one big thing that they were proposing was, you know, opening your window if you can in your operatory. None of that's required. I mean, high vac evacuation is great, and that's definitely something that should be used. But all these other things are kind of just on top of that. And I think anything you can do in your office to mitigate that is great.
And I would agree with Vince and with Marie as well, in that these considerations aren't required. They're things that you can do to help control the virus aerosol if it is created in your office. But there are things that you can also do simplistically, like Vince said about opening up a window, maximizing your HVAC system, making sure all your vents are open, the fans are running on high, leaving the exhaust fans going in your restrooms and in your sterilization and wet labs throughout the day can also help with aerosol circulation. And what Marie mentioned, I think, is very good about making sure that airflow goes from clean to contaminated. So you don't want to have the virus being driven towards areas that should not be as readily exposed, such as your front office area or so forth. But there are a lot of simple strategies that you can apply. There are also a lot of very involved strategies that you can consider. But definitely the ones that are required, take a look at the CDC for some of their suggestions on things that you should consider, and keep it reasonable.
When can we use ultrasonic or prophy jet? Is the high volume suction sufficient if we do use it? What about the relief suction system?
Well, the question that had been posed to me during the symposium about are there any procedures that you cannot do at this time? So the converse to that is that if in your professional judgment you believe that you need to use an ultrasonic instrument, you may at this time, but then make sure that you're employing maximum mitigation strategies, especially during times of high risk. So things that you could be employing beyond the high volume suction and so forth is also four-handed dentistry. See if you can have an assistant assisting you during that time to help control the environment as well. So yes, you can use ultrasonics and other procedures at this time, and it's really taking into consideration the risk and the environment at that time, whether or not you want to move forward with that, and also the risk level and benefit for your patient.
Is it okay for staff to take home scrubs to launder?
Vince?
Okay, so, you know, this goes back actually to the OSHA guidelines from 2003 with the bloodborne pathogen recommendations. So by the letter of the law, no, you're not supposed to take your scrubs home. You're supposed to leave them at the office and have them laundered by a professional service, or have them laundered in the office if you have a washer and dryer. So that's the party line. You know, I guess you could use your clinical judgment to do something else, but it's not what OSHA says. That's the answer.
Can we lock our outside door to prevent people from coming in as long as the door is unlocked from the inside for fire safety?
I don't think that's in our scope here to answer that. I have no idea.
I don't either.
That's not a
The-
regulatory question. That's like a local ordinance fire marshal question.
And I'm not really sure the rationale behind where that's coming from.
On to the next. Are K95 masks sufficient? Do K95 masks need to be fit tested?
Well, a K95, I'll take the first stab, but obviously I'll have you two chime in. A K95 mask is listed as an equivalent product comparable to an N95 mask, and the K designates that it has been fabricated in China. The FDA realizes, the Food and Drug Administration realizes that we have a severe shortage of PPE at this time, and they have put together a list of all equivalents that might be acceptable in our period of crisis. So if you are considering using a K95 mask, look at the FDA list of acceptable alternatives and make sure that that item is on the list. Having said that, the K95 masks are difficult to fit test, if not impossible to fit test, and you don't have as adequate of a seal of an N95, of a K95 mask. So what else? What was the second part of that question, Shauna?
Do the K95 masks need to be fit tested?
So do they need to be fit tested? Well, they can't really be fit tested. You can perform a seal test the best that you can, and that is where you exhale or inhale abruptly, and you're feeling for puffs of air around the perimeter, and then readjust your mask as you begin to wear it. But Chris, do you want to elaborate on that anymore?
You know, I think that, you know, what you had said is absolutely correct. First of all, with the KN95, check the FDA site to make sure that it's an approved KN95. And that's basically one that they take a look at. The FDA takes a look at not only the filtration claims by the manufacturer, but they test the masks to make sure that they are up to standard. There were several KN95s that got flooded onto the American market that later on, although they were provisionally approved, once FDA was able to test them, that approval was withdrawn and left a lot of vendors and a lot of practices holding the bag with what they had purchased. And then as far as fit testing goes, they are considered an equivalent respirator. So I know of people who have attempted to get a fit test using a KN95, and typically that experience did not go well, as Marie implied. They're very difficult to fit test. And that goes to one other thing that I want to say about fit testing. If you do go for a fit testing, recognize that that is respirator specific. So that means that in this time where we really have a bad supply chain and it's hard to get a consistent supply, you're not always going to have a certain brand, say 3M N95 size medium. So when you go to fit testing, they also ask that you bring other samples, a few extra KN95s that you may have in store, different brands, so that you might find one that also works better for you. You may fail a fit test with a certain brand. You may pass one, but find that it's darned uncomfortable for you. And you may find that passing a fit test with a third one, it's comfortable and it fits just right.
We have several patients who are in direct care of COVID patients. When can we see these frontline workers for cleanings or other treatment?
That would be a Vince question.
Sorry, could you repeat that?
We have several patients who are in direct care of COVID patients. When can we see these frontline workers for cleanings or other treatment?
So I believe I addressed that when we were talking about household members with COVID that live with our team members. And basically, I guess they should be wearing a mask 100% of the time, you know, I mean, because if they're exposed constantly to COVID in a different environment, they shouldn't be bringing it to the office, and you don't know when they're going to convert or if they're going to convert to being COVID-19 positive. So technically they should be wearing a mask in the office 100% of the time for source control. And, you know, if they're remotely symptomatic, they should be asked not to work and then be tested. So that's kind of the party line on workers that have a household member that test positive. And I think that would be analogous to that.
And it looks like we have time for just one last question. In the clinic at the prison has no windows or HEPA filters or air purifiers. What do we do in our case regarding the aerosol? Also, we cannot wash our scrubs in the facility or change out of them into street clothes in the facility.
I'm going to take a first stab at this, but I just want to be clear that I've never worked in a prison facility at all. I do know that the CDC does have specific information for infection control in prisons. I urge you to look at that information. If you Google that into your browser, CDC prisons, they will have lots of infection control considerations for you. Having said that, I would ask if you could implement any type of other engineering devices to help mitigate aerosol transmission in your facility. And maybe that's something you could take up the chain of command in your facility. With regard to wearing of scrubs in your facility and you can't change into them into street clothes within the facility. And I want to clarify what was mentioned with regard to PPE a little bit earlier with regard to the 2003 CDC guidelines. In the 2003 CDC guidelines, it states that our scrubs are considered a uniform and the clinical jacket that we put on top is considered personal protective equipment. So historically, it's been okay to walk out of our office in our scrubs, but we must leave our clinic jacket at the facility and not walk around town in that. So I would feel comfortable in the prison setting that you wear your scrubs home. Obviously, your personal protective gown that you wear on top of your scrubs cannot be worn out of the facility. And I hope that you have some means or measures to launder those within the prison system. So with that, does Vince or Chris have any other morsels to add to that?
I agree. It sounds very commonsensical. That's what I would do.
Okay.
And I think also when we take a look at the prison system, again, getting back to community risk, prison systems, at least in some circles, are seeing very high outbreaks of virus. Make sure you understand the community risk that is going on in the prison. And that may not be made readily available because that can be a political hot potato for the administration to let you know about. So get a sense for how the disease or the infection is proceeding within the prison population, and use that information in talking as you go up the chain, as Marie had spoken, to talk about the level of risk in your population and the need to implement engineering mitigation strategies.
Great. Shauna, I do know that there are other questions that we did not have time to address, but I'm hoping that you can save them for Vince and Chris and I, and perhaps we could do something with them at a later date. And I do want to give one last morsel of housekeeping, and that is I have provided a PDF of this PowerPoint presentation to the MDA. in hopes that Shauna can distribute it to all of our attendees.
Thank you, Shauna. Thank you, Marie. Thank you, Vince.
Thank
Thank you
you.
all. Have a great night.
Have a good night.